Capstone presentation by Vivian Lee. Section 1, Introduction. Effective therapy goes beyond simply using the right methods. It's about deeply understanding the client, their thoughts, motivations, and needs. Most importantly, it's meeting them where they are. This paper shares my experience working with JB, demonstrating how recognizing and valuing his strengths unlocked his potential in ways that I had not anticipated. The purpose of this paper is to show you how social work theory and practical skills come together when working with a real client. It'll also demonstrate how and what specific strategies were used based on understanding human behavior and JB's needs. Discussions will include my client's background and the issues requiring intervention. It'll then connect those needs to the specific interventions utilized, providing rationale and discussing the resulting outcomes. During my work with JB, my first priority was to gain a deeper understanding of his diagnosis. Schizoaffective disorder is a complex brain disorder, and I initially had limited experience or knowledge in this area. Taking the time to educate myself was essential in order to provide him with effective support. Establishing a strong therapeutic alliance with JB was key to building trust and creating a safe space for him to engage. I also applied my understanding of human behavior and the social environment, utilizing systems theory to recognize how JB's experiences were deeply interconnected with his family, community, and larger social systems. Demographic. JB is a 60-year-old white heterosexual male originally from Ohio. He resides in a subsidized housing provided through the Florida Assertive Community Treatment Program, or the FACT team, which is where my placement is. JB is currently unemployed and receives Social Security benefits due to his mental illness. His level of education is his GED, and his primary language is English. He has a younger sister who resides in Texas, and she reports that they're very close, and she keeps in touch with the FACT team and her brother on a regular basis to ensure he's getting proper care. She often struggles to understand the nature of his illness and how symptoms can get worse with age. And when JB goes on distressing rants or appears to be in a dark place, she gets concerned and often requests that he get Baker acted. While there are many factors contributing to his alarming behavior, it doesn't necessarily justify a Baker Act. Presenting problem. JB experiences symptoms of schizoaffective disorder, a condition he has lived with since his 20s. He experiences ongoing auditory hallucinations and maintains fixed delusional beliefs, including the conviction that he holds 3 PhDs and is a doctor. While he has pretty decent insight to his medical health condition, his delusional beliefs frequently interfere with his daily life. This leads to episodes where he yells at others, he harasses other doctors, and that eventually gets him removed from public places. He also reports challenges in accessing and maintaining resources. His most recent Baker Act occurred in December of 2024 due to persistent erratic behavior. My client refuses to entertain the idea of moving to an assisted living facility since he has been independently living on his own for a very long time. JB was referred to the FACT team by the state hospital on or about 2005. Referrals to the FACT team typically come from state hospitals or correctional facilities. FACT is a multidisciplinary team that specializes in supporting individuals with severe and persistent mental illness. History of the presenting problem. My client struggles with auditory hallucinations and fixed delusions, including the belief that he holds 3 PhDs and he's a doctor, as said earlier. Um, he's been able to live independently for most of his life, but he appears to be decompensating, showing increased difficulty maintaining his daily living activities and medication adherence. Additionally, JB has difficulty respecting boundaries and often comes to the fact team making demands, um, also believing that he is an employee of the fact team. His behavior can be intrusive and disruptive, requiring frequent redirection. His psychiatric history is further complicated by a history of alcohol abuse, legal issues related to public intoxication. And then he also has a family background, which includes significant losses and a distant relationship with his adult son. My client's first hospitalization for schizophrenia likely occurred in his early 20s, where he was admitted to the state hospital on 2 separate occasions due to worsening psychiatric symptoms. There is a family of there is a history of mental illness in his family. His maternal uncle had similar symptoms, but he was never formally diagnosed. Substance history is alcohol abuse with periods of heavy use and multiple arrests for public intoxication. He reports that his substance use continued till about 2015, and that may have contributed to his psychiatric inability and legal issues. My client has no significant career and made most of his career selling flowers in Houston and in Florida in the streets. He also is currently living in subsidized housing, and his spiritual affiliation is Catholic, but he does not attend church. In the initial mental status exam, my client was dressed in a shirt and jeans with a tie, not specific to any situation. The client appeared moderately disheveled, but his hair was unkept, and the client had a noticeable urine odor. But after a while, we realized that that is just his baseline. Mood and affect was unstable and tearful at times. The client was calm and cooperative. His speech was mostly at a normal rate and tone, but at times the volume of his voice increased during emotional shifts between depression and anxiety throughout the session. The client appeared to be oriented to person, place, time, and situation. His intellectual functioning was estimated to be about below average, and same with his insight. He demonstrated persistent delusions, which seemed to heavily influence his thought process. His responses generally made sense, but again, they were influenced by his belief that he is a doctor, which impacts his logic consistently. He typically does reach the goal of the questions asked of him, though. According to the DSM-5, symptoms suggest schizoaffective disorder, bipolar type, and alcohol dependence. The diagnostic criteria for schizoaffective disorder are interrupted periods of illness, major mood episode, delusions or hallucinations for more than 2 weeks. Bipolar type manic is expansive or irritable mood, increased activity lasting at least 1 week and present most of the day. The mood disturbance includes 3 or more of the following symptoms: inflated self esteem, decreased need for sleep, more talkative, racing thoughts, distractibility, increase in goal directed activities, excessive involvement in activities that have a high potential for painful consequences, and the disturbance is severe enough to cause marked impairment. The bipolar depressive type includes 5 or more symptoms present during the same 2-week period, which are depressed mood most of the day, markedly diminished interest and pleasure, significant weight loss, insomnia or hyperinsomnia nearly every day, psychomotor agitation nearly every day, fatigue or loss of energy, feelings of worthiness, diminished ability to think, and or recurrent thoughts of death. The symptoms cause significant distress or impairment. And then psychotic symptoms of schizophrenia spectrum include delusions, hallucinations, disorganized thinking, incoherent speech, disorganized or abnormal motor behavior, unpredictable agitation, and or catatonia. Intervention. The FACT team enables my client to remain in the community while receiving ongoing comprehensive support throughout his lifetime. Within the FACT program, it provides assistance with housing, medication management, daily living activities, therapy, and most important, it helps clients stay in the community rather than being placed in state hospitals or jail. Another key intervention integrated with the FACT program is that medication management. While his medications don't completely eliminate his symptoms, it plays a crucial role in preventing erratic behavior. The FACT intervention has been essential in maintaining his stability, especially following the loss of his primary support system. He was at one point living with his brother. He had 2 brothers, and both of them died at the age of 40. His mom passed away at the age of 80 something. His father passed away when he was in his early 20s, and he has a sister that remains in Ohio, so he doesn't have a relationship in close proximity with her. The FACT team serves as a substitute support network, providing assistance in meeting his basic needs while helping him integrate into the community. It also emphasizes the interconnectedness of the individual and their environments by examining individuals as part of a larger interconnected system. Without his biological family system, JB is required an alternate support structure to maintain his well-being, which demonstrates how external systems can compensate for the absence of traditional family support. When I first began working with JB, he required medication management only once a week, which is standard for most clients. However, due to an increase in manic behaviors that led him to being Baker acted back in 2024 of December, his care plan was adjusted to daily visits with the team administering his medications once a day to prevent further instability. So one of the goals is medication management, and the FACT team will administer the client's medications every day for 1 month at his residence. This will be assessed after 30 days, and then he will have a psychiatric evaluation once a month to adjust any medications as needed. Psychoeducation will be implemented to provide information about schizoaffective disorder and the importance of medication compliance, just to avoid any future Baker acts. Increase his community engagement is important. He'll attend all FACT team outings as well as any AA outings and LEAP activities for the next 3 months. JB's interactions and engagements will be documented and reviewed. He will also demonstrate appropriate social behavior and reduce the complaints by 50%. We will use motivational interviewing to encourage healthy practices. In order to maintain a safe and clean environment, his ADL assessments will be completed every 6 months for the entirety of the enrollment in the program. The FACT team will monitor his self-care, hygiene, and housekeeping 5 times a week for 3 months during medication drop-off. We'll also implement an incentive-based approach for meeting his goals by verbal praise. And lastly, the intervention is to improve his mental health. We're going to focus on cognitive behavioral therapy to focus on the here and now and breathing exercises, and then specifically CBTP, which is cognitive behavioral therapy for psychosis, by focusing on challenging and maintaining and managing the hallucination and the delusion. The FACT team will implement these evidence-based techniques twice a week for 3 months. To understand my client's needs, I compiled information from several resources. Initially, the state hospital provided his psychiatric, his hospitalizations, medications, and diagnosis history. And then the FACT team gathered further insight through interactions with him and discussions with his sister. We also did an assessment by our multidisciplinary team. And then upon entering the FACT program, a comprehensive biopsychosocial assessment was conducted. The psychiatrist reviewed my client's medications, and since he lives independently, we took the responsibility for medication management. He also regularly meets with a nurse, a peer specialist, and a case manager. This team-driven approach also will allow us to create a personalized care plan that addresses all aspects of my client's well-being. As a part of the medication management plan, I would provide a sleeve of his medications for that day for a period of 1 month. Each morning, I would deliver a pre-dose packet containing his prescribed medication for the morning, afternoon, and evening. This promotes accountability and monitors adherence. He is also asked to return the empty medication sleeves from the previous day. And just a side note, his non-adherence is not willful. It's just really a result of his manic episodes or racing thoughts that lead him to forget. The goal of this intervention is to support my client in achieving 100% medication compliant over a 30-day period, which is essential for maintaining psychiatric stability and preventing decompensation. Another key intervention is the assessment of my client's ADLs, which is a standardized tool administered to all FACT clients every 6 months as a part of ongoing care. While this is routine for everybody, it holds particular significance for JB due to his challenges in maintaining safe and sanitary living space. Unlike most individuals that are diagnosed with schizoaffective disorder, he actually has a high level of functioning. And at 60 years old, he's been capable of living on his own and managing personal hygiene pretty well. During one of my home visits with my client, he sustained a burn on his hand while cooking bacon. He treated it himself by applying alcohol and then just wrapping it. And he never expressed any discomfort, but after we reassessed it and had him seek professional help, we noticed that he had third-degree burns. Most schizoaffective and schizophrenia clients have a high pain tolerance, which is common, and which is also probably the reason why he didn't seek care. But this incident highlights the critical importance of assessing his ADLs. The ADL assessment tool that we use consists of 20 anchors. It includes health practices, housing maintenance, communication, safety, managing time, managing money, nutrition, problem solving, family relationships, drug and alcohol use, leisure, community resources, social network, sexuality, productivity, coping skills, behavioral norms, personal hygiene, grooming, and dress. These ratings are these anchors are based on a scale of 1 to 7, whereas 1 is extremely severe functional impairment, and then number 7 would be the strength is optimal. Community engagement plays a vital role in his overall well-being. and it's critical for those living with schizoaffective disorder. Social isolation increases the symptoms, the hallucinations, and the delusions. So we want to encourage meaningful connections and consistent participation in activities, which promotes stability and reduces his feelings of isolation. He participates in LEAP programs, which happen once a day, 5 days a week, and then AA meetings, which can happen anytime, any day. In fact, outings, which are monitored and documented to assess a consistency and engagement over time. And while my client willingly participates in outings, managing his mood, delusions, and agitation during these events can be extremely challenging. So he requires very close individualized supervision, and it's necessary to ensure the safety for him and the safety of others. CBTP is an evidence based intervention designed to help individuals manage symptoms associated with schizophrenia or other psychotic disorders. A commonly used strategy is in CBTP is the ABC model, which focuses on identifying the activating event, the individual's belief about the event, and then the resulting consequences, including the emotional and behavioral responses. CBTP would be implemented twice a week for 3 months, and tracking is based on the amount and frequency of his delusions and hallucinations. Challenges and future considerations. With consistent reinforcement of these interventions, the objective is to gradually decrease the level of support and then return him to baseline functioning. If there is insufficient improvement, the intervention plan would be extended as clinically appropriate. However, if his symptoms continue to decline or don't show significant improvement after 6 months, we would initiate discussions about transitioning him to an ALF. As my client continues to age, it has become increasingly apparent that he requires more intensive support and supervision, but he remains resistant. And although he demonstrates good intentions and makes efforts towards progress, he is quickly becoming accustomed to the increased attention and support provided through us, through the daily visits. So now he is beginning to expect and occasionally demand the level of engagement, which will present a challenge for the team in gradually reducing the frequency of his visits in the future, should that happen. But his need for intensive services is placing a big strain on the team's limited resources, raising concerns about sustainability and equitable allocation of support across the caseload. As you can see, this is a chart of my results. It lists the target problem, the goals and objectives of the target problem, the outcome, and the status. There is not much change, so we are still currently doing daily medication management. We have reduced his community engagement a little bit because his behavior is not getting better but not worsening. And we're still doing the psychoeducation in hopes that we can avoid the transitioning to the ALF. So, a pivotal aspect of working with JB was developing a therapeutic alliance that fostered trust. My client's growth was mainly the support provided by the FACT team. With a comprehensive team based approach, he had consistent support across multiple areas in his life, from mental health treatment to social services and community integration. One of the key things I learned from this experience is the importance of meeting the clients where they are and using their strengths as a foundation for engagement. Through this experience, the connection between social work theory and practice became very evident. Section 2. In this section, I will explore 3 areas that impact social work practice: ethical issues, human diversity and social justice, and policy issues. These are essential for understanding the complexities of working with marginalized groups, especially within a multidisciplinary setting. Ethical decision making often presents dilemmas that challenge our personal values and professional responsibilities. Social workers are guided by the NASW Code of Ethics to ensure that decisions are informed and have the client's best interest in mind. I learned the importance of understanding tools like the Baker Act, recognizing when it's necessary for the client and when it has the potential to be misused. Working in this setting also has provided me with firsthand knowledge of the ongoing struggles faced by marginalized groups. The last part of this section will address policy issues and their significant impact on the populations served. For this ethical issue, we'll talk about my client, who is a 67-year-old white single female diagnosed with major depressive disorder and anorexia dating back to her early teens. She's a former substance abuser, and she's made over 100 suicide attempts throughout her life, primarily using painkillers. She's been with the VAC team since 2018, and I acquired her in August of 2024. When I first met her, she was hospitalized under the Baker Act due to suicidal ideation, and she's currently placed in a memory care because she's considered a flight risk. A dilemma I've encountered with my client revolves around her finances. She's always contacting her bank to reverse charges from her account because she doesn't want to pay the assisted living facility. And she thinks that if she stops paying rent, the facility will evict her, and then she can go back to living on her own in Clearwater. This is really challenging for her because she's always lived independently up until now. So transitioning to an ALF without pretty much an option can be very challenging. In looking at other ALFs, it was either beyond her budget, it was full, or she's burned bridges with them by not paying their rent and skipping out in the past. My client is also not medication compliant, and she does not have healthy food option. She does not make healthy food choices. She refuses to eat whole foods and consumes ensures and sweets, and a lot of it is probably due to her lack of protein, because she's also a vegetarian. She also maintains a very negative attitude towards the staff at the ALF and the FAC team staff. My client relies solely on supplemental security income, and according to SSI, an individual cannot have no more than $2,000 in their bank account and still qualify for benefits. And since my client has not paid for rent as of September, this puts her at an excessive amount of over $9,000 in her account. So several ethical dilemmas are at play here. My client's desires conflict with the team's responsibility to prioritize her safety and well-being. She refuses to take medication, which negatively impacts her recovery goals, her overall health, and management of co-occurring conditions such as osteoporosis and COPD. The noncompliance also raises ethical concerns because it involves balancing her human right to make informed decisions, but we question about whether her decisions are really truly informed.
The client believes that she's being prescribed unnecessary medications and that the facility is not being transparent with her about her treatment plan, which then undermines her ability to trust the process and work towards recovery. And according to the NASW Code of Ethics, social workers have a commitment to clients to promote their well being and help them achieve their goals, but also address conflicts between autonomy and professional responsibility. This underscores the need to navigate these dilemmas while respecting her rights and ensuring safety. It's an ongoing issue that just worsens over time. She's never satisfied with her living situation, even when she lived independently. And she just feels like she never has to pay rent anywhere she goes. She doesn't get along with anybody. And again, she just refuses to eat healthy meals. It seems like my client harbors significant regret about her past, but avoids addressing the issues. So she remains stuck in the past, and she resorts to self-destructive behaviors, including alcohol use and the multiple suicide attempts. I value the individual's well-being and their right to make their own decisions. And I recognize that my client struggles with major depressive disorder, which makes it really beneficial for her to live in an ALF that has a strong sense of community, where she can engage more and be in social settings and foster connections. So these values align with the ethical principles of respecting the inherent dignity and worth of each person, prioritizing human relationships, if she so chooses to. But managing my personal values while maintaining professionalism has been a very continuous learning process for this client. It's just very challenging for me to understand why she doesn't want to help herself, even with this extensive support that she receives from the FACT team. I sometimes fear that if she were to harm herself, I might feel responsible. But practicing and learning self-regulation, I do remind myself that her choices are ultimately her own responsibility and not mine. So I'm getting better at navigating these challenges, allowing me to just be supportive and understanding with her, and then just meeting her where she's at in her journey, while creating a safe, non-judgmental space. The FACT model demonstrates alignment with the NASW Code of Ethics through several key aspects. FACT addresses the challenges faced by individuals with severe and persistent mental illness. We also advocate for comprehensive and accessible care. It also emphasizes client self-determination by encouraging individuals to actively participate in their decision-making regarding their treatment and life goals, but also supporting their autonomy, because we want to prioritize the well-being of individuals. This approach, combined with engagement of the client's social network, facilitates a holistic and person-centered treatment plan. It resonates with the NASW Code of Ethics, and it creates emphasis on social justice, self-determination, and the importance of human relationships. Human diversity and social justice. Consider my client, a new client, a 63-year-old African American woman with schizoaffective disorder, bipolar type. Her experience highlights how intersecting factors like racial discrimination, the stigma of mental illness, disability, and socioeconomic status create barriers in accessing appropriate services, treatment, and advocacy. I can relate to my client as a female minority who has encountered racism throughout my whole entire life. Unfortunately, systemic racism continues to persist, and so in that way, I can connect with her. Um, at the same time, my client's mental illness, disability, and socioeconomic status add layers to challenges that I have to fully understand. Given these considerable differences, I have to practice cultural humility to better comprehend her struggles. I use active listening to understand her history and educating myself on the systematic issues that impact her. Considering counter transference, I experience moments of frustration and um, vulnerability due to the limited support and resources available that are in the ALF or just even outside of the ALF. Specifically in the ALF where she resides, I feel like she's viewed as just another number rather than an individual with unique needs. With her diagnosis, she experiences delusions and exhibits like childlike behavior. She struggles with boundaries, and when she's bored, she wants to seek attention in ways that um, causes her to behave like a child. And while she receives support from the FACT team, I just believe that she requires more comprehensive care, and the resources that are available make it difficult to provide that type of attention that she truly needs. I held many preconceptions regarding the communication abilities of individuals with SPMI, specifically due to their symptoms and such as like hallucinations and delusions. However, I had a therapeutic session with her, and it involved painting. And while we were painting, she shared detailed and coherent memories of her childhood and her family. I recognized that she was able to recall and articulate experiences with clarity that challenged my initial assumptions. And this specifically highlights the importance of adhering to the NASW Standard 6, which is called Empowerment and Advocacy, which emphasizes the necessity for social workers to recognize the client's strengths and potential at all times. Understanding my own biases, I'm better equipped to empower and advocate for her. The issue of human diversity and social justice is important when engaging with and assessing clients, because the mental health services should be tailored to the individual's needs rather than a one-size-fits-all approach. This empowers clients to take an active role in their treatment by respecting their values and their preferences. I'll use active listening and recognizing their evolving needs and personalizing their care. Offering a client-centered perspective on their medication experience is specifically important because of my limited knowledge in psychopharmacology. Hearing directly from my client about how her medications affect her um, provides invaluable insights that go beyond just standard clinical descriptions. This results in a deeper understanding of my client's needs, and a better therapeutic relationship. Human diversity and social justice are recurring topics in the FACT team's multidisciplinary team meeting. When clients face challenges such as housing, medication, or other immediate concerns, we work to advocate for them. We provide resources and empower them to grow and improve their quality of life. Having worked with this client for a few months now, I initially relied on historical information from old records and input on from other case managers. But during this session, when I took the time to ask her questions directly, I realized that she's an expert at her own life, and she definitely deserves more credit for her self-awareness. So I will continue to engage with her using the person-centered approach. Advocacy is fundamental to the success of the FACT team. We act as a bridge between the clients and their available resources. It involves a continuous cycle of meeting clients where they are and understanding their needs, and actively working to facilitate growth and well-being. Another important aspect of advocating focuses on maximizing access to services and financial resources for the underserved population. It's very important to engage in the political process, supporting and electing officials who demonstrate a genuine commitment to the needs of this vulnerable population. Policy issue. A common social policy affecting my clients with severe and persistent mental illness relates to the Florida Supplemental Security Income, or SSI. SSI is a federal program designed to provide financial assistance to those who can prove a qualifying disability and then have limited income and resources. So the maximum SSI payment for an individual in the state of Florida is $967. As I mentioned earlier, the recipients cannot have more than $2,000 in their bank account, or they can lose their benefits. This policy also comes with significant consequences when these individuals rely solely and heavily on this. And since most of my clients depend on SSI and Medicaid for their financial assistance, it helps cover the costs of living in an assisted living facility. And most assisted living facilities can range from as low as, the ones that I've worked with range from as low as $1,700 to as high as about $3,000 a month. So if Medicaid covers the costs, the Florida General Appropriations Act, which is House Bill 5001, stipulates that if residents reside in an ALF, they would only receive $54 a month for their personal needs allowance. So while $54 a month is intended for just personal needs, the ALF would be responsible for providing meals, room and board, toiletries, and other necessities. However, my clients often feel very restricted in their choices, and they end up purchasing items they prefer since the ALF does not offer alternatives. If given the opportunity to change this policy, I would increase their allowance to $160 a month at the very least, which at the same time would be the same amount as the residents of a skilled nursing facility would receive. I believe it's unfair that individuals in a skilled nursing facility would receive higher amounts than those in an ALF, specifically because ALF residents tend to be more self-sufficient and have a greater need for personal spending flexibility. Community action would be the most effective approach to address this issue as well. Efforts such as writing letters to legislators, organizing petitions, and raising public awareness could help push policy reform. As a nonprofit organization, we do have the ability to amplify our voices and share firsthand experiences to advocating for meaningful change. Policy issue. A common social policy affecting my clients with severe and persistent mental illness relates to the Florida's SSI benefits. SSI is a federal program. It's designed to provide financial assistance for those who can prove that they have a qualifying disability and also have limited income and resources. The maximum SSI payment for an individual is $967 a month. Also, as mentioned earlier, the individual cannot have more than $2,000 in their bank account because that could result in a loss of benefits. This policy has its fair share of benefits, but also comes with significant negative consequences. Most of my clients heavily depend on SSI and Medicaid. Their financial assistance help cover the cost of living in an ALF. And then most ALF can range from as low as $1,700 a month to as high as $3,500 a month. And if Medicaid covers those costs, then according to House Bill 5001, the Florida General Appropriations Act, it stipulates that residents can only receive $54 a month for their personal needs allowance. It's also notable to mention that this amount has been the same since 2001. While $54 is just intended for personal needs, and the ALF is responsible for providing meals, room and board, toiletries, and other necessities, my clients feel restricted and they end up purchasing things because they are accustomed to specific brands or specific types of either hygiene products or toiletries. If given the opportunity to change this policy, I would increase the allowance to $160 a month, which is the same amount that residents of a skilled nursing facility would receive. I think it's unfair that individuals in a skilled nursing facility would get a higher allowance than an ALF, especially because ALF residents tend to be more self-sufficient and they have a greater need for personal spending flexibility. Community action would also be an effective approach to addressing this issue. Efforts such as writing letters to state legislators, organizing petitions, and raising public awareness could help push for policy reform. Since we are a nonprofit organization, we have the ability to amplify our voices and share our firsthand experiences to advocate for meaningful change. It is also important for the ALF to be accountable and provide necessary resources, high quality meals, and make sure that their needs are being adequately met. So to evaluate the effectiveness of this policy, I would monitor legislative updates from the Florida Senate and House bills while maintaining ongoing communication with policymakers to track progress toward increasing the personal needs allowance for the ALF residents. One of the ways I could track assessing the impact on clients could be a key component of the evaluation. It would include tracking out-of-pocket expenses incurred by the staff. I would also analyze the client's quality of life, such as their ability to afford essential personal items, and then access to better foods, and maintaining personal hygiene. Ethical considerations. According to the NASW Code of Ethics, social workers have an ethical obligation to promote the well-being of vulnerable populations and advocate for social change. The policy aligns with the principles by addressing systemic inequalities and ensuring the ALF residents um, are giving them the care and resources that they deserve. This social policy would drive systemic change, and it would address financial limitations in ALFs, and it would benefit all residents, not just my clients who currently struggle with these restrictions. The clients that reside in an ALF have limited financial resources, so they're reliant on these benefits. And when I visit the ALF, I've observed that many of them are understaffed. They provide low quality of care and they offer mediocre living conditions at best. I noticed that the food quality is poor, and it's evident that many facilities cut corners either to maximize profit or just to simply stay operational. Unfortunately, it creates a difficult and unavoidable reality for my residents because they have very few alternative living options. In conclusion, this paper explored my engagement with JB, including attention to ethical considerations, the impact of human diversity and social justice, and policy concerns. Building a trusting relationship with JB and working with the FACT team reinforced the significance of ethical practice and interprofessional collaboration. I learned the importance of advocating for marginalized individuals facing systemic barriers, including racism and limited resources. One key takeaway was the direct impact of policy on vulnerable populations. The social security debate highlights how policy failures can deepen inequality. As a future social worker, I will continue to advocate for my client. Thank you.